All right, mahalo nui for giving me the opportunity to be here again. It's been a while, and what a journey things have taken since the last time I had the honor of being a part of one of your Echo series here. So I'm going to share my screen so that we can all be on the same page, and hopefully that's working out okay. Okay, great. All right, so I am Erin Henderson Lacerdo. I'm the Executive Director at the Association for Infant Mental Health in Hawaii. I really want to mahalo the team at the Hawaii State Rural Association, Health Association for allowing me the privilege and honor of being here today to present to you a very brief introduction to IECMH services and the DC 0 to 5. I want to confirm that I do not have any financial disclosures to report as a part of this presentation. Uh, I wanted to start us off with a little moment. And a few weeks ago, we had our Celebrate Babies Week, where AIMS across the nation got kind of banded together to all do something to celebrate babies in their communities. And one of the things we did was create this image, this handout that I'll share with you. And what we are going to just do is take a few moments. I know that many of us, if you are the busy professionals I assume you all are, we don't take the time to often pause. We get so caught up in the day, running from appointment to appointment with millions of things to do on our task list, and between work, home life, and personal aspirations, we often don't have a chance to slow down. And when we get a chance to slow down just a little bit and be a little more regulated, we're better able to respond to the world around us. And so we created this handout for families that we handed out as part of Celebrate Babies Week, and I'll just share this with you today. So we'll just take 3 deep breaths together. And if you would like to join me, I would love to have you with me. But Hanu, to inhale, to take a deep breath in through your nose, and Ha, to breathe out, to exhale, to release through our mouths. So Hanu Iloko, 1, Hanu Iwaho, Hanu in, Ha out, Hanu in, Ha out. And I thank you for allowing me this moment because it's also a reminder to me to slow down even in this space today, as we have lots to cover and not as much time as we would like to spend, of course. So as part of this handout, we wanted to share with Makua, our parents, that they could practice this with their keiki even as young as they might be, and that keiki do have big emotions and feelings, but might express it in different ways than what we as adults might do. And so, as Makua, it's important for us to be there together with them so that we can help them to regulate their emotions. And as a quick activity that they could practice with bubbles, bubbles would be a nice little way to teach babies and young children how to practice blowing. And so, just wanted to share that all with you and to take a little bit of a moment before we get started. Today, we are going to cover 3 things. We will want to, of course, always start off with definitions and making sure that we have the same kind of frameworks. So we're going to talk about infant early childhood mental health services and developmentally appropriate diagnosis. We're going to also have a very brief overview of the DC 0 to 5, as well as what's its distinguishing components. And I want to also share about some of the work that's being done here in the system that is going to support the specialized treatment that's needed for young children and their caregivers. And I have had a cough for like the past month, so don't mind me. I might have to take a break while talking. So I apologize in advance. All right, so during this first portion, I do want to ensure that we're all on the same page and have a shared understanding of infant and early childhood mental health services. I'd like to start off with this definition that's from a national entity called 0 to 3. And it's that infant and early childhood mental health is the developing capacity of the infant and young child to form close and secure relationships, to experience, manage, and express a full range of emotions, and explore the environment and learn while in the context of family, community, and culture. And so this is a way of bringing us all together so that we can have this same kind of framework, that it's not that mental health really is about this capacity about around relationships. And so it's really important that we also consider not just the baby, but the baby in its family, in its community, and its culture. And one of the things we do best in infant mental health is to do what we call keeping the baby in mind. And as such, I invite you to see the many faces of my son. He's a lot older now. He's 5 and in kindergarten. All these were before he was 2. And I'm sure that many of you have littles in your life who experience this full range of emotions and then some. And as you can see, so many of these emotions can be seen just by the images on this screen. There's so many different feelings. He's got contentment, he's got worry, he's got fear, he's got excitement, to questioning. And who are we? When we look at this as a whole, we think, well, of course, babies have emotions and feelings. And sometimes we kind of forget that they do, and we kind of expect them to roll with it the way adults would. But they're still making sense of all of those things. And so if we believe that babies have mental health, we also need to believe that they need specialized support in order to reach their optimal development. And as people who specialize in children, we know that the critical nature of brain development at this time of life, and one of the many challenges to providers, is that what do we do once we know that something needs to be done and we don't always know where to go for that kind of support. And so I want to share with you what we kind of termed the infant and early childhood mental health continuum. And it's really important to see this as a continuum of services, that it's not just one type of service, that there's many types of services that actually do go in to support the mental health of young children. Promotion and prevention is where some of you might fall as pediatricians if you are kind of primary care providers who then would refer to other services. Your role would really be to help identify that those keiki need additional support and link them to those places that then could provide that specialized support. And some of you, because I see a colleague on the call who I know is somebody who does assessment, diagnosis, and treatment in infant and early childhood mental health. And so there are some of you who will fall on in some way, shape, or form on this continuum. It's really important to think about what your role might be at this point in time, and then what type of resources you might want or need to connect to so that you can then support young children in your care. And as we shared already, there are special considerations to make during infancy and early childhood. And one of the most important considerations is the fact that there is no such thing as just a baby. There's always a baby in someone. This is a critical underpinning, because if we care about babies and young children, we have to care about the adults in their lives. And as we see that this child in the middle is dependent on the quality of relationships around this child, right? What are the caregiving relationships? What are the family relationships? What is the child's relationship with extended ohana, their community? What service providers are in the life of this keiki? How do service providers work with these caregivers? Are these relationships healthy and optimal? Do they need additional supports? There are many questions we have when working with young children, not only because they can't necessarily tell us themselves because of their developmental skills, but honestly, their very survival depends on it. We know that the survival of children is dependent on those who are caring for them. And that quality of environment is really what we hope for to be optimal so that this child can thrive. Another way of viewing what I'm sharing is through the lens of early relational health. This is an emerging term for the same thing that I just shared about. How safe, secure, nurturing relationships last for a lifetime. And that this is one of the primary developmental tasks of this age group. And if this sounds familiar to you, that is because the AAP has released many statements on early relational health and has guidance on how to discuss this with your patients. 0 to 3 and the Early Relational Health Center have also released joint statements reiterating the the intersection and commonalities that they're really the same thing, maybe just described in different ways. And so we're really all trying to do the same thing, which is ensure that children have safe, stable, nurturing relationships early in life. And that if there are challenges to those safe, stable, nurturing relationships, that they have the appropriate supports to help them. And my hope is that we have, at this point, established some common language around infant early childhood mental health. And then I want to turn now to some of the treatment services that are available for these young children. And my hope in sharing this with you is that you might be interested in referring some of the patients in your care to services such as these. And I hope you do. One of the, I won't be reading this. I'll talk about it and give you some time and space to read this. Uh, One of the services that's Infinite IECMH service for treatment, I should say, is called child parent psychotherapy. And it's one of the most evidence-based models in the nation and is also growing in other parts of the world. It's designed to treat children ages 0 to 5 who've experienced trauma. And going back to what we just talked about with infant early childhood mental health, thinking about how the child is in the environment of their caregiver and their caregiving relationships. It's important to note that in some places, the child doesn't have to experience the trauma in order to receive services. And that's because if the parent or the caregiver has experienced the trauma, then the child is now in an environment that has experienced trauma. And therefore, the child may receive treatment. And I share this because not all children are going to be symptomatic when they show up in your office or in your clinic or in your space. They may not always be clinically symptomatic or clinically diagnosable um, for some of the things that might be presented to you. And it's just important to think about how might we then support or think of how do we support families even in those cases as well. And so child parent psychotherapy does allow for treatment of children in this way. And what's really important is that it's not the child themselves by themselves that's getting treatment. It's really a holistic approach of ensuring that the child and the caregiver come together because we really see the relationship as the mechanism for growth and change. One of the things that's really important for child parent psychotherapy is the triangle of explanations. And I'm not going to be reviewing CPP in detail. This is not an informational session on CPP. I did want to share, however, this really important component. This triangle guides treatment, naming in a child-friendly way, in a developmentally appropriate way, what's happened, which is what we call this right side of the triangle, the behavior, the feelings. Um, on the left side of the triangle, we might use that as an opportunity to name their experience. And on the bottom part of the triangle that connects it, right, is how are we going to work together in our sessions with the therapist, the child, and the caregiver to provide protective steps and hope. And so this is important because CPP takes into consideration both triangles of the child as well as a triangle of the parent or the caregiver. And these triangles might look different. Their experiences might be different. Their behaviors might be different, but yet they impact one another, right? And so these triangles and understanding these triangles are really critical to the therapy model. And that's also why dyadic treatment is really important. And I think about sometimes when uh, sometimes I'll have parents who are talking to me and they're really pushing for this happened and we need to do X, Y, and Z. Their experience is very emotional for them. It's still very hot, perhaps. And some of the children, maybe their their behavior is very different, even though they've experienced the same situation. And so this is why it's really important to consider both sides of the both triangles at the same time. And that's really that role that the therapist is playing is to kind of help to translate and name some of these things. which is different from some other models that might be out there that might only work with a child by themselves and do not include the caregiver in the treatment model. And if we have this framework of a child being dependent on a caregiver, and then we have the child in therapy, but the caregiver not in the sessions, it might be really challenging for that therapist to make progress because, as we know, young children, they do things on their own time very often. And I think a lot about times when children are in car seats and in the car ride, and they decide to say something, or they are taking a shower and they remember an experience they had. And those are moments that a therapist is not going to be present for. Those are everyday life moments that a caregiver is the one who's present for. And so it's really critical for the caregiver to be able to provide what we call the protective shield kind of as often as possible, utilizing all these opportunities and not only staying within this therapy session, we're going to practice this thing. That truly it is all the times and all the experiences that this child has with this caregiver that's going to be part of their healing. So I hope that makes sense in terms of why at this age, dyadic treatment would really be one of the most effective ways to make an impact on young children. I want to go next into the diagnostic classifications of mental health and developmental disorders of infancy and early childhood, 0 to 5. We call this the DC 0 to 5 for obvious reasons. It's a very long title. And while I realize it might be abrupt, it really is important for us to think about, well, if we're talking about specific services in this age range, how do we then, how do we do that? How do we do that? So for kids under the age of 6 years old, the best practice is to use the DC 0 to 5 as opposed to, or in conjunction with, I guess I should say, the DSM-5. The DC 0 to 5 uses a multi-axial approach, which for those of you who are familiar with previous versions of the DSM, that did also use a multi-axial approach for the diagnosis of young children in order to make sure that providers using giving diagnoses are considering the context in which these symptoms exist. And so in using the DC 0 to 5, you first are going to consider the caregiver and child relationships and caregiving environment. Then you would move on to the physical health considerations, anything the child might be dealing with physically or mentally that could be causing some or all of their symptoms. Then we would move on to psychosocial stressors. And this is where we see a lot of those traumatic experiences show up. We consider how those experiences could be impacting the child's development and the reported symptoms. And after this, then you would consider child's developmental competence, looking at all domains of a child's development. And then we get to a point where we might be able to consider the diagnosis of a child. So as you can see, it's a very long process in effort to fully understand the context of which this child is existing, living in, and what some of the challenges they might be facing. And some things that we know, right, is typically, this is, I shouldn't say we know, I should say typically what we experience is that parents will express concerns at about a year to 18 months of age. And before that, parents kind of hope that things will catch up or that those skills will emerge. But it's about that time when we'll kind of see parents identifying that they have some concerns. And if we're looking at autism as an example, children may receive a definitive autism diagnosis at around that 4-year-old mark, right? After a lot of those verbal skills may or may not be present, or other social skills that we might expect. And however, there is an early intervention window time frame, right, which we all know is birth to 3. And so when children have some of these diagnoses later or are identified later, they might miss some of those essential services if we wait for a long period of time. And so the DC 0 to 5, excuse me, is a manual that provides some of these early diagnoses that we might not see until a little bit earlier so that we can then provide services at an earlier age. I hope that makes sense what I'm saying. Okay, great. Thank you for nodding. All right, so um, we have on this slide four, I will disclaim as made up children. These are all hypothetical children. These children each have a different set of presenting symptoms. I'd like you to take a moment to review these and kind of jot down your initial reactions or hypotheses as to what potential diagnosis they might have or what track you might kind of go down when looking at a child with these symptoms. I would like you to also think of what questions do you have and what information do you need? It's purposefully vague. Okay, I'll give you a moment and drink some water. Okay. And I know it's not a whole lot of time. We still have a little bit to cover, and hopefully we'll have some time for questions and answers if there are any. Um, Either questions or answers for that matter. Um, Once again, these are hypothetical children. Oh, shucks, I deleted the slide that has the answers on it. Well, super handy. Um, in that case, I'll have to go based off of memory. But oh shucks. Well, as we say, um, releases from perfection because I did click the button and now they're there. So here we are.
Okay. I will not pull
All right.
mine either then because I just found them too.
Okay. Well, in good news, we found them. Here we are. Okay. Thanks for your patience with me as I juggle all the screens. Um, these are what we would say are textbook diagnoses, right? Based on the limited information available on these hypothetical children, once again, we would look at child A having a potential diagnosis of autism, child B having a potential diagnosis of oppositional defiant disorder, child C having a diagnosis of PTSD, and child D with a diagnosis of ADHD. And so, what I'm hoping that came up for you while I was nervously looking for my slides is really some questions. What information did you need more? What more information did you need? I'm hoping some of you wondered how old the children are. I'm hoping some of you wondered, um, some of these symptoms kind of seem the same. I'm not really sure how to approach this if all these children are having these similarities. So that is one of the reasons why it's really important for us to take the time to get to know the children and their context, not just the children and what's being shared with us, but that the context that they are coming to us in. Now, I'm going to share a couple of slides that are kind of dense in the sense of you could probably spend a lot of time looking at them. Um, but the next two slides are fairly similar, but kind of presented in two different ways. So on this slide, we've compiled the symptoms of each of these diagnoses, some general symptoms. ADHD here in this purple circle, ASD in this blue circle, anxiety, which is something we didn't talk about yet, in this circle, and trauma in this circle. And in this Venn diagram format, you can see that there is quite a bit of overlap between all of these, as well as some that are specific to the one that's in the circle next to them, right? So this is, of course, the Venn diagram where the overlapping indicates it's in both circles. So diagnosing children can't only be about the symptoms. There's too much overlap between diagnoses for us to only look at symptoms. And all of these diagnoses share the same symptoms that parents may commonly report to us: learning challenges, sleep challenges, social challenges, oppositional behaviors, difficulty regulating emotions, sensory concerns, low self-esteem. And so it's really important that we take that time, or somebody takes that time, I should say, to understand the symptoms within the context of experience, development, and relationships in order to make an accurate diagnosis. And so understanding all of this, once again, takes time. We're not going to get all this information in a 15 to 20-minute visit. It it will require additional time to fully understand the context of these symptoms. And that's where it might be important to consider referring this child and family to someone who can do a thorough assessment before making a formal diagnosis. On this next slide is kind of a similar way, but just in a chart format, which might be a little, I just figured, different people might process information differently. So I wanted to bring both of these slides in today. So this is another way of viewing how these symptoms are overlapping. And it's really an easy way also to see how easy it is for misdiagnosis to occur, or that maybe the recommended intervention might not be the appropriate treatment for what the symptoms are that we're seeing if we don't have the chance to look at the underlying causes. And so it's really important for us to have professionals who have the skill set to, and time, I should say, to provide accurate diagnoses for young children, especially when we consider developmental milestones and stages. And so proper assessment really is, and diagnosis, excuse me, is really important for kids. Accurate diagnosis can make all the difference in terms of treatment, in terms of services and support. And this is the start of their lives and their engagement with services and other systems. So it can allow them to receive the treatment they need. It can also not give them access to the treatment they need. It can give them access to additional supports in school and work as they get older, and it may allow them to access other services. And once again, or not, right? If a child carries a diagnosis that perhaps is inaccurate, then they might be receiving treatment that's not appropriate for what they have. So diagnosis for children may impact their identity development. Diagnosis at a young age can lead Keiki to believe that there's something inherently wrong with them, or that they alternatively have a superpower. So it's really up to how this child processes their diagnoses, how their family supports them in these diagnoses, and how this diagnosis is talked about. And so it's really important for us to consider, right? Why would we need to make a diagnosis or have someone make a diagnosis? What is the benefit to the family? What is the benefit to this child? And how can we then support this child's development, optimal mental health development? I want to share a really brief case here for a moment of a 5-year-old that I encountered. When I met basically the presenting, this is me as a consultant to preschool classrooms, and so not a treating physician or primary care or anything like that. I am an LCSW, and serving as a consultant once again to this preschool classroom. They gave me a call about a child who's 5 years old, male. He qualifies for DOE evaluation, qualifies for the Department of Education special ed services under the category developmental disorder. The presenting concern that the preschool had, however, was that he was having a lot of behavioral challenges in the classroom, using profanity. He did not sit for a long time. He needed a lot of support regulating, following directions, was very impulsive. He also was pretty aggressive towards his peers as well as the adults in the classroom. I also got informed that he had a diagnosis from a child psychiatrist that he had autistic disorder and he was prescribed with Vispridol. Now, I paused at that time because I had seen this child in the classroom a few times. And the more I thought about it, the more uncertain I was about this diagnosis, primarily because we learned a lot about the family. So when we learned about the family, we learned that it was his second year in the program, that both of his parents had completed and been released from drug rehabilitation programs in his lifetime. He resided in a recovery center with his parent. Both of his parents moved in with grandparents in a low-income housing complex. The mother had reported that they were sleeping in her car following arguments with the child's father and was therefore working more hours because she was unable to provide shelter. She was trying to make more money, basically. We also were informed that the child was brought to school recently by the grandmother as opposed to the parents. And at that point, she had disclosed that the child was in her care as a result of the police arriving due to domestic or intimate partner violence activities in the home. What we learned was that the father was shooting his bow and arrow while also arguing, and that the child was present during these arguments. We also learned that the child got removed again from grandmother's care because there was a registered sex offender in the home. So as you can tell, he was placed in many different places in a short period of time. This all took place within about 5 months. We have the school also noticed that the resurgence of the profanity seemed to be happening recently, and that there was a period of time where that behavior had gone away and had come back. So as you can see, understanding the family story and understanding what's happening to this child in the context of his environment is really important to understanding what might be the appropriate diagnosis for this child. Just based on what I'm sharing with you today, my hope is that you might wonder about the diagnosis of autistic disorder, as well as the prescription, unless there is other information. We learned too that the treating psychiatrist, they had a few visits, but was not somebody who was treating this child for a long period of time. So what I mean is this psychiatrist was not in a relationship with the family, a long-term relationship with the family, but more in a short-term diagnostic capacity. So there are some gaps in the system that exist, and I'm not saying that, things are um, I am certain that there are measures that were used and rationales given for these specific things. And I'm wondering if the diagnosing psychiatrist might have a different diagnosis should he have had the opportunity and the time to sit with this family for a longer period of time and further understand what supports and what this experience of this child was. Um, And on that note, I want to talk about some of the systems efforts that we have underway. Because as you can imagine, it is costly both for children and for systems. Um, if we if things if we expect children to fall in the same systems of care as adults. So I did want to share about the financing policy project, which is a I guess, a technical assistance team that was established a few years ago to advance infant and early childhood mental health policies that will contribute to the healthy development of young children. And Hawaii was selected to be a part of the cohort in 2023 and implementing financing strategies that will better support this continuum of promotion, prevention, diagnosis, assessment, and treatment efforts. And so here are the names of some of the participants, or actually, I hope all. I did get it from the TA, from the facilitator. So I hope all of the providers or the contributors to this work. And as you can tell, there's people who are on this call today who are also part of this project, but also many people who are in different sit in different parts of the 0 to 5 system. I want to share that some of the priorities for this year and starting from last year and into this year were to provide were to conduct a baseline survey on the provider workforce, and as well as create a crosswalk for that specific to Hawaii, and which would crosswalk the DC 0 to 5 to DSM and the ICD-10 as well. And then lastly, to design an infant early childhood mental health bundle payment pilot as well. And so these are some efforts that are underway that we hope will address some of the challenges that I brought up today, such as time, access to these types of professionals, which means having trainings available for these professionals, and then also payment. That these services are once again different from the way in which we might treat adults, and therefore might require more time and expertise. I want to share that we are very excited to do kind of a soft launch, if you will, of the DC 0 to 5 crosswalk. We're not doing a we're not quite ready for our unveiling party, but I did want to share that this does exist, that MedQuest recently published a memo around the DC 0 to 5 crosswalk. And I do hope that this is a tool for you that you'll be able to utilize in your practice, and or at least the awareness might help you to then refer to a clinician or provider who does utilize this as a diagnostic manual for them. This is a pullout from one of the, actually it's the first table in the crosswalk. So I just wanted to show you as a few examples of what the DC 0 to 5 has listed as a disorder, the DC 0 to 5 codes, the ages that they might utilize that specific diagnosis for, the related DSM diagnosis and code, as well as the ICD-10 classifications and codes. So this would, the goal of this is to help to identify the codes that might be available to you in order to bill, as well as just to think about diagnostics differently, right? That it's not necessarily the DSM, which we know is designed for adults and has its own slate of shortcomings as well as strengths. And the DC 0 to 5 similarly will have its own shortcomings and strengths, however, does take into consideration age and developmental stages. And before I wrap up, I just wanted to share, going back to the tie-in to child-parent psychotherapy here, is this is an example of what some of the work for child-parent psychotherapy, which is once again an evidence-based dyadic treatment model for children ages 0 to 5. And you see all the green. Oh, it's a little blurry, I'm sorry. All of the green are sessions that you might have only with the caregiver. And then it's not until session 6 or so that you would bring the child in for their treatment services. And so our current billing system doesn't quite cover the amount of sessions that we might need for this type of foundational phase. And so that is part of what we're hoping to address with the bundle payment pilot project. so that that there is adequate compensation for those who are doing developmentally appropriate treatment models. I hope that makes sense. And that's one of the biggest connection pieces I hope you can see that's really a thread throughout this work is standing up and making it sustainable for these kinds of clinicians and providers to be able to have practices in our state. So in summary, I'd like to uh, hopefully I've covered all the things that I said I would. Helping to share about the treatment services for IECMH as being dyadic work, that it takes time to provide developmentally appropriate and accurate diagnosis, that the DC 0 to 5 is the developmentally appropriate nosology for children ages 0 to 5, and that there really is a team trying to make a lot of these things sustainable within the state. And hopefully we are able to uh, uh, make a lot of those things happen. Um, I wanted to transition briefly into just a few of the next steps that you might be interested in or you might want to share with some of your colleagues. Is our organization is really about building a network and professional system of care um, in infant and early childhood mental health. And in doing so, we are offering a training series coming up soon. It is free. It's actually underway. And I'm bringing this up because we do have a DC 0 to 5 training that we are hosting at that time. So I did want to share that with you. And if you are interested in, say, a developmental screening tool, the ASQ and the SE is something that is used often in pediatric practices. And we have a training coming up actually in a few weeks. These are free. So once again, no financial issues here. It is a free program that we're offering at this time. And hopefully is an example of some of the things that we can do to provide support in the system. And with that, I think I will pause for guidance and questions and answers.
We have the poll loaded with your post-session questions if you want us to launch that first and discuss them.
Right. So, Erin, maybe you can just go over the questions that were not where everybody didn't get them right.
Sure. I could see the answers as people were filling them in. I was like, oh yeah, I forgot to mention those things. So, yes, one, diagnosis in early childhood should take development and trauma into consideration. Thank you all for saying yes. Um, Number two, which of the following are not considered IECMH mental health services? Um, this was a little tricky because I didn't actually name all of these things. What is good news is everybody did not answer CPP. So that is really the best news. And I think, we could have some debates in the field about whether all these are IECMH services or not. Traditionally, the one that would be the correct answer here is play therapy because typically play therapy is with a child and a therapist alone. So it is not a dyadic service, but I didn't talk about the other two. So give yourself some credit if you as long as you just didn't answer CPP. Attachment and biobehavioral catch-up is also a dyadic model. It is a short-term brief intervention that happens. And parent-child interactive therapy is once again a dyadic model. That's the one that we often refer to as the one with the bug in the ear, where there's the earpiece and the therapist is coaching the caregiver in a separate space on how to interact with the young child. 3 is all correct and 4 is all correct. Okay.
Great. Good job, everybody. And Anderson, I can't even talk. Erin, thank you so much for a really great presentation. I have a couple of questions. I'm going to start us off, and then others feel free to add your questions in the chat. One, I was thinking about the financial sort of pressures that we as a state are under currently. I imagine that there's data about the payoff from doing this in terms of preventing need for services later and the, sort of maybe increased economic output from children who get this kind of services or, things like that. I'm curious what kind of data you could share with us that might be good for us to know about the economics of it.
And this is where I'm very grateful to have colleagues in the space who are much better at those kinds of data points. I'm looking at the two who are off camera, both Keikos actually, but Christina and the actual Keiko. More because I don't want to misquote, but do either of you have anything handy? If not, I would be happy to look something up after and provide that information to you because I do think there is information out there.
Yeah, I'll start, Christina, the other Keiko, if that's okay, and then please feel free to jump in. Sorry, Maya, I just sent it out to remind people that this it was starting.
I know
So
it happened to me too. There were two of me a few weeks ago. I didn't,
sorry, I can't keep track of myself.
yeah.
So yes, that's a great question. In fact, there has been national studies, and I'm trying to find it as quick as I can to show the return on investment for
Just general summary is helpful.
treating, yeah. So I think we've always been using this, the fact that we've done some financial scans. And actually, Christina, the other Kekonita, is working with the Children's Funding Project to do like a fiscal scan for all ages of children 0 to 21. And then I think we want to dig a little deeper to really figure out what is it that we're spending in terms of current views so that we can do an accurate return on investment. Christina, did you want to share more though?
Yeah. Sorry, I have sunglasses on. I couldn't find my, these are prescription, and I couldn't find my regular ones. They're in my house somewhere. Um, a few things. That question for specifically just kids who have only had this and showing outcomes. I mean, we intrinsically sort of know that that would be a good thing, but that's emerging. They call it emerging. They're collecting that right now. When you're looking at specific kids, absolutely at the anecdotal level. But when you're looking at kids that are provided holistic supports and families holistic supports over time, with this being part of good childcare and all those sorts of great things that are so important for children. I think Heckman does a great job. The Heckman equation is a really good sort of compendium of data around if we take good care of little kids, including infant early childhood mental health and many of it. And I can send a link. I'll put a link in the comments. But that's a really good one. That's over 13% ROI, return on investment, for every dollar put in. There's many others, but that one I always tend to go to because it's really easy to look up and it's fun to play with and stuff for people. So I'll put a few in there for you. And also for those that support them, it doesn't, Erin, you haven't talked about reflective supervision or anything like that and supporting those that support the children. There's definitely some research on less staffing turnover of, because you're all supporting these families and those kinds of stories just break your heart. As Erin, the example she showed, and that can really, as can really hurt the physicians and the counselors. So
Thank
yeah,
you.
that's the main one.
Yeah.
Yeah. There's a question in the chat from Eden. At this stage, would it be appropriate for parents, families to be aware of this? For example, to ask their provider about if they have a concern about how their child is being evaluated and / diagnosed, or if they are looking for a provider.
I say yes. I say yes. It would be really helpful for families to be aware that there are people in the community who are specializing in this young age group and that they should ask questions. I mean, I feel like that's kind of a big thing, right? Is that sometimes parents just don't know what questions to ask. And so when a physician tells them X, Y, or Z, or any type of professional,
Mhm.
sometimes they accept that and they don't necessarily seek otherwise. So I would hope that families would be aware. Yes.
Thank you. Are there any other questions, folks? Renata's bringing up the importance of taking care of adults in geriatrics, which I was sort of wondering too about whether there are any similar interventions for pregnant and birthing people, because a lot of this might theoretically start before birth.
I'm glad you asked that specific question. Child parent psychotherapy does have support and can be started at in utero during pregnancy. Sometimes we know that there are, once again, going back to that model of parents who have experienced trauma,
Mhm.
might need additional support. And also, there are some other models that I think are still kind of gaining interest in terms of like peer partner support, for example, um, for pregnant and parenting women. And so I know for example, Women's Way through Salvation Army, they have child parent psychotherapy therapists on staff.
Mhm.
So there are ways in which this is being integrated into those types of systems of care. And no, thank you, Renata, for that a little caveat there. I think you're hitting the nail on the head with all the people who care for babies matter, and that even if you're only treating adults, most adults are parents or caregivers of some sort and may make a difference in the life of a young child. And so even if you are only treating adults, do you know if they have kids? Do you know if their kids need support? Are we even asking? And so those are kind of that's the framework this is me, your social worker talking, right? I want everybody to adopt. And I know it's not everybody's framework, but that's of course the Kool-Aid juice I've drank over the years. My
Thank you.
bias is showing.
But we see the downstream effects. I'm a hospitalist. When I see the 16-year-old come in and everything just feels so completely unfixable, it's, I think back to what could have been different at 6 months or 4 years old. And it can be really emotionally draining as well to feel
Yes.
when
Yeah.
there are solutions, but they're just slow to be implemented and hard to access, despite all the work that you guys are doing to make it more accessible, which we, of course, appreciate so much.
Yeah.
Yeah.
And
So,
as if a closing comment for that part, which I think was really fascinating. I was talking to a preschool teacher about teaching, like playing games with children and helping them learn how to be like good losers, if that makes sense, How
Yeah.
do you lose a game? And she told me this story about her 16-year-old nephew who literally playing Candyland lost and had a complete meltdown and blew out. And she goes, guess he should have learned that in preschool. And I'm like, yes. And so it starts at a young age, and we have the ability to intervene younger. And we might see that at 16, 17 years old, playing
you're so
Candyland.
right, because I made a policy around age 4 that I would not play if my daughter freaked out, if she lost. And we had many meltdowns, but now we could play any game all day long, and she's just completely fine if she loses. And I'm really proud of that little parenting thing.
That's wonderful. We need to teach children how to win and how to lose. Yeah,
Yep.
it's part of it.
Oh, what a wonderful presentation, and just so much great learning for all of us here. So thank you so much to Erin and to all of your partners in this work who joined us on this call. We really appreciate having the opportunity and look forward to inviting you and the rest of you all back soon to talk about this more.
Thank you once again for the opportunity to share.
You all have a wonderful day. Bye.